In anesthesia, we want to make sure the patient is safe and comfortable and pain-free, and at least normal function has resumed within the first 24 hours for those who are admitted. For those who are sent home, we in hospitals have a method in which we actually get in touch or ask the hospital to get in touch with the patient to ensure they are comfortable within the first 24 hours after surgery. One of the most important things about the anesthesia, admission of anesthesia, is personnel. You require people who are well trained, people who are competent and able to get this message across and able to look after patients through the whole patient process.
You titrate it, give it slowly, but you can give up to 100 milligrams if the patient is in good health and under 50 years of age. Usually we use 75 most of the time. And then if the patient is over 50, you've got to be very careful and give her 50 milligrams of pethidine slowly with 2.5 milligrams of Domicom, midazolam. So we're going to give the dawa now. She's got a line inside. This is the medicine we are giving. This is sedates the patient. This is not general anesthesia. This is local anesthesia. Right? Yes. Takunja mguu ya juu, nerosha hii ya chini, ulale na upande namna hii, penduka kidogo namna hii mama, ndio sawa sawa. Are you comfortable? Jacinta? Good. So give it slowly. In the meantime, you test your equipment. That's the light source. That's your camera. You switch on the suction. Okay, just hold on there. It's important that you check the equipment before you start using it. Alright? You increase your sedations in a stepwise fashion to make sure that the patient is nice and comfortable. Meanwhile, your endoscope has been immersed in Sidex, which is to disinfect the endoscope. And you want to make sure that it is functional. Alright? The important things are that the endoscope is blowing air. As you see, it's blowing air here. Okay? Is it blowing water? Let's see, water is coming out. And is it sucking? It's sucking. You see the water coming in this tube and then it's sucking. So we've got a functional endoscope. The last thing you want to do is check that the wheels are moving. This is up. This is down. This is left. This is right. This is the insertion tube. This is the umbilical cord that connects to the light source and the suction, and a water bottle. All right? Focus. Okay. That's the most critical part, going through the cricopharyngeus. If your patient is comfortable when you do that, then you will have a good look. All right? I'm going to connect the camera now and show you that we're in the esophagus. Okay. So if you look at that, that's the esophagus. We're going down the esophagus. So vuta pumzi pole pole mama, vuta pumzi kawaida pole pole. You see that she's got a small hiatus hernia, the stomach coming up. That's the OG junction. The pink mucosa is the stomach. All right. And as we go down, that's the endoscope. It will enter the stomach now. The camera is not very good as we get close. That's the stomach now. You can see the rugae in the stomach, all right? That's the rugae in the stomach. There's quite a bit of acid lying around there, which is normal. Vuta pumsi pole pole mama. Yeah. You come to the pylorus. Now this is the antral area of the stomach. You'll see a black hole, which is the pylorus, which is that one there, the black hole there. That's the pylorus. You look at the antrum and you see no major lesions. You're looking for major lesions on your way in, and then in detail you look at the anatomy when you're coming out. So going to get into the pylorus. That's the camera. That's us in the pylorus now. That's the duodenal bulb. At the junction of the first and second part of the duodenum. And then we'll get into the third part of the second part of the duodenum now, as we are there. Okay, let me just see, the camera's blanching out, so we're just going to have a look and then introduce it. We're in the duodenal bulb. Okay. All right, in that. Okay. We're fortunate the patient didn't have any serious pathology, otherwise we picked up every sort of pathology that you can think of in this theatre. We picked up cancers of the stomach, you've seen them, duodenal ulcers, hiatus hernia.
Before everyone leaves, you do the sign out. Has the name of the procedure been recorded?
Yes.
And it's been confirmed that all the specimens, you didn't take any specimens. Any equipment problems that needs to be addressed? Any key concerns for recovery for this patient?
No, just observations for the next 1 or 2 hours, and she wakes up and she goes home.
Thank you very much.
Thank you. She's okay with that. But she may have some other gallstones. Have you done an ultrasound? Ultrasound is normal. Is she constipated? So that's what you need to address. Yeah. Thank you very much. So now,
tumefanya hiyo kesi ya vile tulikuwa tumetarajia kufanya, na tumepata akona shida kidogo, lakini si shida ambaye ni kubwa sana. Acid akonayo katika pahali pa kukunywa, pahali dawa inapitia. Akona bit of hyperacidity. Tumbo yenyewe haina shida kubwa. Tutaendelea na madawa, alafu utakuja kutuona baada ya mwezi clinic, tuone na tutatue kama anaendelea vizuri ama kuna kitu nyingine ambayo tutaendelea nayo.
Ndio.
Sawa. Uko na swali lolote?
Hii acidic hasa uletwa na nini? Kwa sababu amekaa nayo for about 5 to 6 years.
So vile tunasemanga, kila mtu ana produce your acid. Hata wewe unajua kila mtu ana produce your acid. Kuna kiwango cha watu ambaye wanakuanga na acid ambayo inaongezekanga kwa mwili, na kuna pia vyakula ambaye watu wanakula ambaye inawaletea hiyo shida. Kuna kadi ambayo nitakupea, imeandikwa chakula ambaye anafaa kupunguza. Unajua sisemangi watu waache, juu kikataza mtu kitu kabisa wanaanza kuitafuta na njia ya nyuma ya kuikula, lakini kama anaweza punguza pia hiyo inaweza msaidia kiasi. Alafu pia kuna vile mtu anaenda kulala, tunasemanga baada kukula mtu anangojea masaa kama 3-4 kabla alale, ili chakula ikuwe imepita, imeingia kwa tumbo kabisa. Sawa. Okay. Alafu pia kitanda yake kama unaweza mwekea pilo 3 hivi ili inuke kidogo
kwa kichwani.
Kwa kichwani. Itasaidia pia. Yeah.
Hivyo ndivyo nakaa.
Sawa.
Na je, tuseme kwa mfano sasa hizi dawa ni za kutibu ama ni za kutuliza tu? Hizo
dawa kazi yao ni kupunguza ile acid iko kwa tumbo. Hiyo dawa ndio inapunguza hiyo acid kwa tumbo, si itafanya acid ipotee ama iponyeshe kabisa. Lakini kuna wengi ambao wanakunywa hii dawa na wanapona nayo.
Na je, hii dawa iko na madhara baadaye natis?
Hii dawa ile tunakuandikia iko na madhara, lakini si ile kiwango cha kupindukia. Si dawa ambaye niko na tashwishi nao na kwa yeye kwa kukunywa.
Okay.
Juu hata alikuwa amekunywa kabla tufanye hii procedure, ni tu kuhakikisha hiyo shida ndio ile alikuwa nayo.
Okay.
Sawa. Haya.
Na je, sasa tuseme umenipa mwezi moja, ikionekana kuna improvement?
Hakuna improvement, utakuja, tutaongea vile anasikia. Kama kuna improvement, kuna kitu nyingine tutafanya.
Okay.
Yes. Labda tutasema tunataka picha ya tumbo, hiyo ndio tutafanya.
Okay.
Sawa. Lakini tunaanza na dawa, tuone vile dawa zinaendelea. Kama dawa zinaendelea vizuri, tuendelee na madawa. Kama iendelee vizuri, ndio utaenda na.
Asante.
Sawa.
Asante sana.
Sure.
What are the post-procedure, let me call it complications or expectations that he and Jacinta should expect after this procedure? Any discomfort or any effects of the procedure that they should look out for so that in case it happens, they don't panic or they're not worried about it?
So this is a relatively minor case, and Professor has clearly, I think they have had this done before, but one of the things they may is a little bloating because the Professor inflated their stomach a little bit, so they may feel a little bloated, and then also the effects of the medication. She's gotten drugs that put her to sleep and made her comfortable, so she may feel a little sleepy and drowsy, and so we advise for patients, because this is a day case, that they should not drive themselves home, that she should be accompanied as she has been until she gets home, because she may be drowsy for the rest of the day. If she has a little vomiting, also that may happen. It's not common, but it can happen every once in a while.
Once the patient has finished the journey, or you have finished the journey with the patient from the before surgery space into the intra-surgery or intra-op space to the point we said you actually have handed over in the recovery room, the patient then is fit either to go home or to go to or to be admitted back to hospital, either in the ward or any other space within the hospital. Now, for the first 24 hours, for those patients who are admitted, there are issues the anesthetist needs to look after, and he does look after. One is the issue of pain, which is usually more often than not what brings even patients to hospital in the first instance. The other thing that you also find that the anesthetist must look after is to look after all other systems to ensure they can get to the stage whereby you can be functional. For example, you have had an operation in your tummy, on your bowel, or on the uterus or any other site, and you can't eat for some time. We have to look and ensure that you're getting enough fluid, enough water, enough salts, enough glucose, and of course antibiotics to ensure that you don't get infection. We also then bring in other members of the team appropriately or accordingly. For example, as we said before, for the person who has had surgery who needs to be assisted to move, that also comes in and comes about. For the patient who requires other medication to be brought back on board because he had pre-existing diseases like diabetes or hypertension or any other disease with any other organ, we actually tidy that up and ensure you're functional and able to get back to a status whereby you can become a productive member of society. So for the first 24 hours, for the patients in hospital, the anesthesiologist will still see you, will still play a big role to ensure that the safety of your recovery, of your journey, is prime and important and is undertaken well.
As I mentioned earlier, everybody has a duty to perform. Everybody is important, all right? So the nurses, before they start the operation, count the number of retex they have. These are gauzes with the radiopaque marker. We must always use instruments, gauzes with radiopaque markers, all right? That's the first thing. The second thing is they count them at the beginning, and before the peritoneal cavity is closed, there's a count done at the end, all right? If there is any one missing, all right, then you got to stop, look for that, and then start the closure. So if corners are cut and you don't count and you start closing, then you will have these problems, which should not happen. These are very, very easy problems to address, and that should never happen in our setup. So if we have everybody's role identified as to what they're supposed to do, all right? And we do it step by step, then we should not have these complications in surgery. Just like the gauze, all the instruments are counted. In fact, the instruments, the artery forceps come in packs of 10, all right? So when they're open, there's a big clip that holds the 10 together. You open. So when you're closing, the nurse, the scrub nurse, is supposed to address all these issues. If there are any gauzes packed in the abdomen or instruments are left in the abdomen, all right? So the scrub nurse has a way of marking on the table, okay, of the point that there is a gauze left. So when the operation is over and they start closing, she looks at the table and she says, you put one gauze behind there, we need to get that out. If there's an instrument that was left there, she has a marker there. It's very easy to mark these things. But when the person does not mark, does not count, is when you get these problems.
And in the event that any is left, or any instrument or any gauze is left, how is this then addressed to be able to retrieve it?
The patient should have an X-ray done immediately afterward if there is any suspicion. And if something is left behind, then you've got to address that issue. and find out, okay, this patient needs to go back to theater and that foreign body needs to be removed. And it's a very straightforward procedure to remove these foreign bodies, but when they're missed and they're picked up late is a problem, which should not happen.
The error comes when you don't have qualified people, or when the doctors you have can't recognize their limit. So do you want to do something for money or what? But us, as a Christian institution, trying to give back to the patient, to go to the community. And I told you they qualify doctors, and you don't come with mind of money. So you have to do things properly. For example, the patient comes to outpatient, you will see by the MO, and we have clinic for consultant, and you do all the exams necessary before going to theater. And the qualified guy will do the surgery. So in that case, we avoid those kind of error. You don't come, for example, from outside, and MO will see you and go to do something without consulting the consultant.
People who are trained as anesthesiologists are also trained in critical care medicine. Critical care medicine is that branch of medicine that looks after patients who are in the intensive care unit. Patients in the intensive care unit are those patients whom, either because of trauma, meaning physical insult to the body, or because of an overwhelming disease process, find themselves unable to function well, and so need support for the various systems. For example, support to breathe, support to maintain a blood pressure, support for the kidneys to work, or for the brain to be active. Now, the government has done very well in buying equipment to support the critical care or intensive care units in parts of this country. But there's a shortage in that. We do not have adequate personnel, both the doctors and nurses, to man this. So one of the things that the Society of Anesthesia has been looking at is to improve training for people who have just finished medical school to be able to be part of the people coming in to manage on a day-to-day basis the patients who are in the intensive care unit. And that's an area whereby perhaps as we expand training opportunities for anesthesia providers, we can be able to also look at empowering the medical officer, meaning the doctor who just finished internship, to be able to have some of that knowledge to assist in managing those patients. Because we, yes, have invested heavily in that equipment, but in the personnel, both for the medical officer and the nurses, we are still at a shortfall as a country. But it's an important part because we are seeing more and more of the accidents, we are seeing more and more of the stronger superbugs, we are seeing more and more of the older patients who require surgery, who may actually require that kind of support, because as we said before, surgery is a physical insult to the body that can actually also push you into the intensive care unit.
When you start training people, you have to improve the level of the hospital. Yeah, because now how can you train somebody when you are not qualified? So even the nurses, they have to know that we have a trainee in the hospital, and it has really improved also our services, because we have, for example, COSEXA in surgery, we are training, and even in the ward, you can see that services are really improved. We don't do things by routine. So you have to read, you have to teach, and the level of services has improved.
The thing to remember, as people dealing in healthcare, is never to look at an item, for example, training anesthetists, as a vertical cost, meaning don't look at it as an initial thing of how much does it cost now. Look at it as a whole process, as a horizontal cost. It is a journey which, if you have adequate safe perioperative space, safe anesthesia space, what it means to all is that the outcomes will be good, the mothers will be well, able to get back functional, the babies will be well, people will not have to keep going out of the country for very basic procedures to get done. So you always look in medicine at horizontal costs, never at a vertical spot cost.
Medical errors can occur in any facility, even the best of hospitals. But following the set standard operating procedures, proper communication and teamwork among the medical personnel is the key to ensuring patient safety, especially in surgery. That's where we wrap up this episode of Health Digest with me, Dr. Mercy Korir.